Paul, I was feeling depressed, so my wife put her hand on my shoulder and said, Earth. Paul, it meant the world to me.
All right. Yeah, I could not have predicted where that one was going. All right, great.
All right, one more.
Sure.
Paul, did you hear that a man was caught stealing at a supermarket today while standing on the shoulders of a couple of vampires?
No, I did not hear that, Matt.
He was charged with shoplifting on 2 counts.
Both really solid.
Really solid.
Great job.
Thank you to punstoppable.com for that one.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul?
I am indeed here, Matt. How are you?
I'm doing well. We're hanging out with a good friend today, Dr. Ted Parks, talking shoulder. And Paul, before we get to that in his bio, can you tell the audience, what is it that we do on the Curbsiders?
Sure, Matt. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you mentioned, we are joined by the great Dr. Ted Parks, who's been with us. I think we're up to, I guess he gets a smoking jacket at this point now, right?
He gets at least a smoking jacket.
Yeah.
At least a smoking jacket. So another fantastic conversation with him, teaching us about how to sort out this continuum of shoulder impingement. And we talk glenohumeral joint arthritis. We talk AC joint arthritis. Really practical stuff, as usual, Ted. And there is a physical exam video we'll post as well to go over some of the maneuvers we talked about. So our guest today, and another fantastic conversation with him, is Dr. Ted Parks. He's an orthopedic surgeon in Denver with a clinical faculty position at the University of Colorado. For the last 25 years, he's been teaching orthopedics to internal medicine residents destined for careers in primary care. And we were talking beforehand, Paul, he's been doing this conference apparently for 20 years plus, teaching knee and shoulder. And you'll be able to see why today because he's such a great educator. So we will get on to it, but I should remind you that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. And a reminder to sign up for our Patreon at patreon.com/curbsiders, where you can get twice monthly bonus episodes, ad-free episodes, access to the CashSlack Vault with all our show notes and figures and everything, and a lot of other cool stuff. So check it out, patreon.com/curbsiders. Ted, good to hang out with you in person again.
Likewise.
And this is now, I've lost count, maybe 5 or 6 years, Paul. What do you think?
It's about right. Yeah, we were just, before we started reviewing the body parts that we've covered, and I think we managed to cover most stuff at this point now.
Yeah, so we'll have to think about what we can do for future episodes.
Find new joints.
Ted's already been brainstorming that, so
Highway
audience,
bone
don't
pathology.
worry.
Yeah, there we go.
So Ted, if they've heard your previous episodes, which they probably have, they know a little bit about you. But tell me, what is your current hobby or interest? What are you tinkering with these days, or what's taking a lot of your time?
Well, I got to admit, the thing that I'm spending most time on now isn't something I'm really passionate about, but it's been forced upon me. And that our practice in Denver, our orthopedic practice, has used paper records from 1936. Actually, we chiseled them into stone before that, but we used paper records until like 4 months ago. And we switched to an electronic medical record, and wrestling with that beast has like occupied every second of my waking and a lot of my non-waking hours. And I've got to figure that out better. It's working now, but it's taking a ton of time and a ton of time after work just to get caught up on the dictations I'm not doing like I used to be able to do them on the fly. Everything was set up in the old days to maximize the doctor and patient's experience, but it was really hard on billing and all the other parts of our practice. So the EMR is definitely helping those parts of our practice out, but man, it's making documenting and the patient-doctor interaction a little more difficult.
Yeah, those ortho chicken scratch notes that are like 3 sentences long.
I can't even, yeah.
Paul, I've always been very jealous of them.
I mean, this is, because, I mean, previously, so you have the band.
Yes.
You were putting together cars, you were designing video games. I think the last time we talked, we're doing photorealistic paintings of that. So this is grim. I don't want
Oh, it's really grim. Yeah. Yeah, it's a sad chapter, isn't it? So hopefully by next year I'll have something more fun and exciting to report. I'm still doing all those things, but man, this is a big burden. The EMR has been tough.
Well, Matt and I don't think I'll mind me saying this, are old enough that when we were in residency, our first year we were still using paper charts, and we actually had to go in the back room, and there were shelves with cranks on them that you had to sort of move to actually be able to actually get to the chart that you had. So this is, I feel we went through this a while ago. I won't date us, but yeah, it's not fun.
Paul and I basically became friends with stacks of red charts. We were answering phone messages from patients, and that's how old we are, audience. Yeah,
well,
that's how old we are.
I can relate. I'm way older than you guys, so.
All right. I think it's always easier learning from you if you sort of set us up with the anatomy that we need to know first, and then we can kind of go through the cases. So what anatomy do we need to know?
Yeah, I'd love to use the model. I know that the people who are only listening to this and not able to see it, this isn't going to be that helpful. But essentially, things get confusing right out of the box because we talk about the shoulder joint, and there isn't a single shoulder joint. There's the glenohumeral joint between the ball and socket, the ball being the top part of the humerus and the socket on the scapula. But there's also a smaller but still important joint between the clavicle and the acromion, and that's the AC joint. And there's even another joint that probably isn't worth talking about, an articulation really between the scapula and the chest wall, which we call the scapulothoracic joint. And
I never really thought of that as a joint.
Don't ever think of it. It's a waste of use your brain for something else.
I'll leave that one to you.
Yeah, I even leave it to other people myself. So yeah, really there's just two. And both of them can have trouble. So we need to understand them both. So it's already confusing anatomy-wise, just the fact that we say there is a shoulder joint. There are two. So we said before that the glenohumeral joint is the articulation between the humerus and the scapula, and that the AC joint is between the clavicle and the scapula, a special process on the scapula, which is called the acromion. And if you come up behind somebody, or even on yourself, if you feel back there, you can find the scapular spine. So it's a ridge of bone that goes from medial to lateral, and it's this ridge of bone on the model. And the scapular spine morphs into the acromion. So it looks like a hockey stick. The shaft of the hockey stick is the scapular spine. The blade of the hockey stick is the acromion. And there's a lot of pathology when we talk about impingement related to the acromion. But in this instance, we're just talking about it as being half of the AC joint, acromioclavicular joint. So we've got the humerus, we've got the clavicle, and we've got the scapula. And I always like to ask the residents to draw those. And people do a great job with the humerus. It's like a stick with a ball on the top. And they do a pretty decent job with the clavicle. It's kind of like a curvy rod. But man, drawing the scapula is very challenging. I mean, I see these all the time. It's a challenge for me to draw them. The important features there are the scapular spine in the back. Again, you can, while you're listening to this, just feel back on yourself. You'll feel it. And if we took the humerus off of here, you could see the socket of the glenohumeral joint, which is the glenoid. And it's a very different looking socket than the hip or other sockets and joints. It's very small. It's like the surface of a golf tee instead of a bowl that captures the ball. And being less surface area and being more like a golf tee, it gives us the opportunity to move in a lot of directions we couldn't move if it were more captured inside a deeper socket. But there's also an opportunity for instability that doesn't exist in a more constrained socket. Features on the scapula, we talked about the glenoid. That's an important one. The scapular spine, which terminates in the acromion. And in the front, there's a little finger-like guy that sticks out, and that's called the coracoid process. So that's really all the anatomy on the bony side that you need to know. The other thing that's important to know is the rotator cuff muscles. And we all had to memorize their names, which is probably kind of important. But the concept is even more important, that these are muscles that originate on the scapula, on the shoulder blade. They go out and they attach to the humerus. And just like the cuff on your shirt, and that's how they got their name, they go all the way around the front, over the top, and around to make a big circle. And their purpose in life is to hold the ball into the socket. We talked about the socket being kind of small and not with big walls and the opportunity for instability. One of the things that helps keep it stable is the dynamic force of the rotator cuff holding the ball in the socket. And the cool thing about it is those muscles communicate with each other to adjust their tension so that just like men around a fireman's net no motion because everybody's pulling the right amount to keep things centered. So in different positions, these rotator cuff muscles are adjusting their force to keep the ball in the socket. So it's a pretty sophisticated little machine to keep that ball in that barely socket-shaped socket. So that's the stuff we need to know. There's also another thing on this model, which is the biceps tendon, specifically the long head biceps tendon. So the bicycle gets its name because it has two tires. Biceps has two tendons, one like a millimeter longer than the other. So we call it the long head. It's kind of we could have done better.
It's only a millimeter long? I thought it was longer.
It's a little bit longer. It's not
Yeah.
so long that you really would look at the two and say, oh, look at the long one. There's one that's like, is that longer? Yeah, I guess if we like just put a tape measure on it. So I don't know how they come up with long head biceps tendon because it's a little bit longer. But anyway, that long head one, it travels under the acromion. So it can also be a victim of subacromial space impingement. And that's worth knowing about. So we keep that on, that's on the model, and it's worth mentioning.
Yeah. So to recap the little bit about the impingement stuff, the rotator cuff muscles can impinge, the biceps tendon can impinge, and I guess the bursa, which is there as well, which is not on the model, but that's the other thing that can impinge.
Mm-hmm. So anybody who's living under the acromion can impinge. And the reason impingement happens is that when a human raises their arm, in this case, I'm demonstrating abduction. So I'm bringing that's the snow angel motion. I'm bringing my arm away from my side. And if you can see on the model, the space, which is big enough for my chubby index finger, gets awful narrow when I get up high. At about 90 degrees, it gets down to like a millimeter. And if you have anything that makes this a little more swollen, or you grow calcium on the underside of the acromion, which is very common as we go through life, you can actually strike the rotator cuff or the bursa or the biceps. Any of those occupants of the subacromial space can get pinched against the acromion. And then once you pinch it, it gets swollen. And once it's swollen, it's going to pinch easier the next time because it's too big. And then the pinching causes swelling, the swelling causes pinching. It's kind of like if you bite the inside of your cheek and you keep doing it, and the more you do it, the more you're going to do it. So impingement's a lot like that. And with impingement, the more it happens, it's even happening on the model, you will start to fray the tissue. And the rotator cuff can get thinner and more frayed. And one day you'll be doing something pretty trivial, like taking a big garbage bag and putting it into the dumpster, or throwing a baseball pitch that you've thrown a million times,
Right.
and pop, it goes. A rotator cuff can tear. So rotator cuff tears are not like other muscle tears. Other muscle tears are a normal muscle that experiences an overwhelming force and tears. These are abnormal muscles that experience a normal force and they tear. And they tear because they've been set up for that with years of impingement and attritional wear of the rotator cuff or the biceps. And the biceps, people that, we've all seen them with the Popeye biceps and all that.
Right.
They tear theirs. Typically, it's nothing really extravagant. They lifted something, and maybe it's a heavy something, but it's something they've lifted before. But it's just that event was the straw that broke the camel's back, and it was a setup because of that acromion sawing against it for months or years.
And I know we're not going to get too much into the biceps tendonitis, but if that long head of biceps tendon tears, your book mentions that it's only like you only lose about 5% of your strength.
It's a trivial strength loss for elbow flexion and a little more for supination, but really the functional deficits are so trivial that we don't advise fixing it. And we advise people to leave it the way it is. We've got backup tendon, the short, little puny short head. It's a millimeter shorter than the long head. That one's still intact, and it doesn't go anywhere near the acromion or any other dangerous thing. So it's gonna last us the rest of our life. So I always tell patients, it's hard to convince a patient that we're not gonna fix this when they first come in. Yeah. And I just tell them, hey, look at this. Let's pretend that you and I both have a rope on that doorknob, and we've been shutting the door together. And now my rope broke, but you and I are now pulling on your rope. We still are pulling really hard. We got the same amount of pull. We just have one connector instead of two, but that one connector is plenty strong to get the job done. So they still want the surgery, but
of course, something's broke, they want it fixed.
Exactly.
Paul, this rivalry between the tendons of the bicep reminds me of like my brother and I are twins born by a cesarean. He's older than me by like 30 seconds. So he's always like, I'm your older brother. And I'm like,
I was just thinking, like, I love the dual nature of the orthopedic surgeon where, like, you have this reputation because you're using, like, hammers and just, like, wailing away in the OR. But then also, like, yeah, when you evaluate the knee, there's, like, 2 millimeters of translation you'll feel. I'm like, no, I will not. Like, so you guys, you have, there's some subtlety here is what I'm saying, which I appreciate.
But I say I do,
yeah, sure.
well, Paul, why don't you read our first case here? And this is a shoulder case, obviously. So let's get into it.
Great. Let's talk about James. James is a 45-year-old gentleman with high blood pressure. I guess he's too young to be a gentleman. He's a 45-year-old male with high blood pressure who presents for routine physical. He's requesting labs and a referral for a colonoscopy at the behest of his partner. While he's here, he also thought he'd mentioned that his left shoulder hurts when he's getting dressed or grabbing his coffee from the top shelf. The pain radiates to the mid-humerus. He cannot sleep on his preferred left side due to the pain, and sometimes the pain even wakes him up from sleep with his left shoulder pain. So because he's having some discomfort, he's, of course, requesting an MRI. So we can get into whether or not that's warranted and where to go from here. But what questions will we start with? How do we take a good shoulder history when we're asking James about his ongoing shoulder issues?
Yeah, good question. So the elements in his history that help me the most are that he has the pain with overhead positioning of his arm. And sometimes we'll say also lifting objects at a distance, okay? But overhead is really the one that helps me the most. It's not specific for impingement, but it definitely is consistent with impingement. And impingement is so common. It's almost like I'm anchored to it from the beginning, and you have to kind of convince me it's not impingement if it's a shoulder problem, because so many of them are. But he's got those two factors that make sense. And the reason why it makes sense is, like we showed on the model a second ago, when you raise your arm either in abduction or forward flexion, or many of the different positions in between, you are narrowing the subacromial space and potentially impinging the structures against bone, which causes pain. And that is where he's finding his pain. Like everything else in life, it'd be unusual to see this in an 18-year-old. As we go through life, we tend to calcify the underside of the acromion, so the space gets narrower. It's already, right out of the factory, it's narrow. But as we go through life, it gets narrower. So the fact that he's middle-aged, that also is a clue for me that he might have impingement. I wouldn't even think about it in somebody if he were 21, for instance.
So I know you think about this, and in your book, you write about this being like a continuum when you're thinking about this impingement that,
Yes.
that we've been talking about. Can you tell us about the continuum of impingement syndrome?
Yeah, I'd love to, because a lot of the people I talk to here, definitely patients, but also other medical providers, will say, the shoulder's always been a mystery to me. Are we talking about impingement, or are we talking about rotator cuff? Actually, impinger sort of a blanket diagnosis that covers bursitis, so subacromial space bursitis, which is shoulder bursitis, the bursa that lives between the rotator cuff and the acromion. It's an occupant of the subacromial space and can be impinged. And once it's impinged, it can be swollen and red and angry and tender. So it's definitely on the continuum. It's sort of the least severe of the different things on the continuum, because nothing's really torn, and the rotator cuff is healthy and strong and intact. But the bursa is angry and red and swollen and inflamed. So if you go a little farther on the continuum, sort of the more severe, or maybe if you have impingement for longer, then you actually impinge against some of these other structures, like the rotator cuff. And I have to say rotator cuff because which rotator cuff it is going to change depending on what position my arm is in. The one that gets impinged upon the most is supraspinatus, because it spends way more time than the others under the acromion. So if you want to take a shortcut, you can say, okay, we're going to be talking about supraspinatus, and you'll be right most of the time. But the other ones, anybody can be there. Teres minor, which is way down here, you'd have to work for Cirque du Soleil or something to be able to get that to impinge against your acromion. So we can omit that one.
So we're subscapularis,
Yep.
supraspinatus, and infraspinatus.
Exactly.
Are the ones
those, if you just remember those three, those are the only three you need to know. So getting back to your question about the continuum, bursitis is the least sort of severe example of impingement, but it is impingement. The next is impinging the rotator cuff against the acromion or the biceps tendon, but not torn. It's just that they're inflamed. They've bumped against the acromion. They're a little swollen, a little bigger, so they're apt to do it.
They're mildly irritated.
They're mildly
like
irritated.
Paul
Just
is most of his time. Yeah,
exactly.
At baseline.
Yes, exactly. And then the next step after that, if that happens enough, just by physically rubbing against the bone, that inflamed rotator cuff is going to start to tear. And it's just exactly like wearing out a kneecap on your jeans. At first, it's kind of white and fuzzy, and then it's kind of stringy, and then you can see your skin under there one day. And that's how these tears happen. You're just physically like grinding your way through the tissue. And if it gets thin enough, you can have an event where you lift something and the tear propagates because the tissue was so thin and weak from attritional rubbing against the acromion. And that's how most rotator cuff tears occur.
We're excluding all the cool people who have ripped jeans and they buy them that way.
Yeah, exactly.
Right? These
Like my daughter used to pay extra actually
Yeah.
for the big hole in the front. Yeah.
No, we're talking. These are the people that earn the rips in their
Exactly,
jeans.
yeah.
The analogy works for those people. Okay,
Right.
all right. So it's a continuum of like bursitis, all the way down to like full tear.
Mm-hmm.
And then how are we going to figure this out? Can we figure this out clinically without an MRI, like our patient is asking
Yes,
for?
we can make some grounds toward figuring out for sure. The physical exam can help us a lot. And let's say that we have a patient in whom we suspect impingement. Maybe it's this patient that Paul presented to us. And one of the things that we'll do to help confirm that that's the diagnosis is we'll actually take their hand or their arm and lift their arm up to cause impingement. And I'll do it in abduction and I'll do it in forward flexion. And if I get to a point in that range of motion, and this is what we call passive range of motion because I'm doing the motion, the patient's just passively letting me do it. If we get to a point in that passive range of motion that recreates their symptoms and it's up 90 degrees or above, that's a check mark in the positive that this might be impingement. The other thing I'll do is I'll have the patients bring their arms behind their back like you're getting arrested kind of situation. And by doing that, I'm taking this angry red neighborhood that I want to press on, but it's hard to press on it in this position because it's the acromion is kind of blocking me from pressing on it. If I put their arms behind their back, it brings it out front. And by pressing on the anterior part of the shoulder, and if that's really tender compared to their opposite side, I always do it on both sides because some of this stuff is kind of like, pressing on your eye. It's not comfortable naturally. But if there's a big side-to-side difference and their effective side is much more tender, that tells me that that it's also a positive sign for impingement. And a lot of people will say, well, does that mean it's the biceps? It doesn't really, it's not that specific. It just means that neighborhood is inflamed and angry. And I brought it out under the protection of the acromion and I'm pushing on it now and it's sore.
Okay. Yeah, because you can feel the biceps tendon on some people, but I'm always like not sure. Am I really feeling the biceps tendon, or is it one of the others? So you're just saying,
Yeah, and I'm not even sure myself.
We're just okay.
But we don't have to be that
That
specific.
is so refreshing, Ted.
And honestly, I don't think I've ever seen a case of rotator cuff impingement where the bursa wasn't involved and the biceps wasn't involved to some. It's a regional thing in these structures that are under the acromion. So they're probably all involved to some extent in
Paul, I
condition
like
of
this
impingement.
kind of imprecision. This
Sure.
is good.
Yeah,
I don't.
It's all
right
kind of angry
place.
in there. It's just
Yeah, this is great. That's why we love having you on the show because you simplify things. You tell us what we need to know. We don't have to be like, you know what I'm saying, Paul? This is.
I hear you.
No, and like most subspecialties, we like to complicate things to the point where it's funny. When I work with the residents, I'll have them go into a room to do a shoulder exam. And they'll spend, like I have to call security actually to get them out of there after a couple hours. And then I'll say, well, what'd you do? And they'll 20 minutes of I did Hawkins, Nears, and all these names of different people. And at the end, they're just swimming in confusion. I mean, it's almost like I did better before I went in the room knowing what's going on. So I think we overcomplicate things. The honest truth is it's a pretty simple little machine, and there are a couple little tricks that we've evolved to help us out. So trying to keep it simple, I think, is really valuable.
I feel like your clinic sounds different than mine, where I'll have someone go in the room like, and what did your shoulder exam look like? They're like, well, I just kind of moved it around. And it's like, all right, well.
I guess because they're with an orthopedic surgeon, they figure they
Yeah,
have to
right.
pretend that they.
I think we're all in medicine, so we're all trying to do our best and be complete. I think we're all afraid of missing something, and when you don't know what you're doing and you're afraid of missing something, you do a lot of unnecessary stuff. You just shotgun everything out there. So.
Good point.
So we were talking about sorting people on the continuum, and I got to the point where we were talking about bursitis and how it's positive in that you can recreate it by putting them in the impinging position. You can find it by finding tenderness when you press here. And then at that point, when we have those two positives, I still don't know where they are on the continuum, but the next step can help me get there. And what I'm going to do next is I'm going to check strength and discomfort on rotator cuff strength testing.
Okay.
This is where you can get into some names and some tests. And the simple ones to do are to have the patient start with their elbows at the side, the bank robbery position, elbows bent 90 degrees, elbows at their side. And that's sort of the starting point. And then ask them to external rotate, okay? And then have them externally rotate both sides, right and left, against you. So I put my hands like that. Their hands are inboard of mine, trying to push out against
so this
me.
is active external rotation.
Active external rotation, arms at your side. And you can get an idea of their strength and if it hurts them to do that. And then I'll put my hands to block them from internally rotating, and I'll have them internal rotate against a resistance. And then I'll do the third test, which is harder to remember, but that's where I'll have them stick their hands straight ahead of them and then turn their thumbs to the ground. And it's the position you would be in to empty 2 cans on the ground, okay? And then in that position, with your thumbs down, push up toward the ceiling. And that's a test specific for supraspinatus. So external rotation against resistance helps check the infraspinatus. The one where you internally rotate against resistance helps check the subscapularis. And then the empty can test is the test we use to check the strength of supraspinatus. So let's say in that same patient we were just talking about, they've passed with flying colors, no pain and no weakness, side-to-side comparison on any of those. Then I would say they have bursitis, because the rotator cuff is healthy, it's happy, we can make it work and it doesn't complain. It can't really be too badly inflamed if we make it work like that and it doesn't cause pain. Same patient, they do fine with external rotation against resistance, internal rotation against resistance, but on the empty can, it hurts and they're weak compared to the other side. We know we're at least a step farther on the continuum. It's not just bursitis, because supraspinatus is angry and inflamed, and when we ask it to do its job, it hurts. So you've now made one step up I can't tell you yet if that supraspinatus impingement is a tear, because that would cause pain and weakness, or if it's just an angry tendonitis, that would cause pain and weakness. But if I do my next step, which is I'm going to give them, let's say I give them a cortisone injection, and my cortisone injections contain 4 cc's of lidocaine, and I go answer a couple painful phone calls, come back, and then I check them again. And this time, let's say the weakness goes, their strength returns, and the pain is still there. I said that backwards. Let's say the pain goes away and the strength comes back. That's a good argument that this is not a tear, okay? But if the pain goes away and the weakness persists, that could be a tear. Do you see what I'm saying?
Yeah.
Because in the unanesthetized subacromial space, the weakness could be due to pain.
Right. That's a common dilemma, and I think all the joint stuff we've talked about before. Is it true weakness, or is it the pain that's causing them to not go through the range of motion or to feel weak? So
yeah.
And then for us, I mean, if we're not doing injections in the clinic, I guess if the weakness is maybe mild, are we still okay sending these people to physical therapy, or should we be going for MRIs at this point?
Even if you had an MRI that showed they had a tear, you can be safe to send them to physical therapy.
Okay.
There are, especially as you get older, and if north of 60, I mean, if you took a lot of people 65 and older and made them get an MRI in their asymptomatic shoulders, you're going to see a lot of partial tears and even some full thickness tears.
Yeah.
It's just the gray hair and wrinkles of the shoulder. We all get it as we get there. And we have to be careful not to overtreat that, because it may not be the source of their pathology if you identify it. So these physical exam maneuvers that elicit pain are more helpful for me. And what's really helpful for me is if I do a subacromial space injection and there's pain goes away, it helps me feel more confident that it's impingement pain, because that shot isn't into the glenohumeral joint or other places, the AC joint, that could be causing pain.
Yeah. Okay, so we've talked about the continuum. We've talked about how bursitis is kind of that's the milder end, all the way up to the full tears is the more severe end. And we started to get into talking about treatment a little bit here. So physical therapy is not a wrong answer for anyone necessarily, but are there cases where we should refer to you first, or we should get an MRI before we send them to physical therapy? Yeah,
it's a really good question, because there are data, and it's probably true, that if you end up having to fix a rotator cuff tear, and it's an acute tear. Now, not a lot of these are acute. They're way more often sort of, like we said, an attritional tear that finally gets to completion. But let's say it's the minority of tears, which would be like you get in a car accident and you take a healthy rotator cuff and tear it. those tears do better if you treat them more
Okay, that makes sense.
immediate to the injury, but that's a really small minority of these tears. So I'm not going to talk about those. Let's say the more classic attritional tear, you can do a lot with physical therapy. And certainly you're not burning any bridges by trying it first. What we can do in physical therapy is the subscap in the front and the infraspinatus in the back both have a little bit of a downward force vector. And if we strengthen them, we might be able to afford a millimeter of down position of the humerus, which this is a game of millimeters. So if we can get a couple millimeters, that can help.
Okay. Most of what I'm seeing, Paul, and you're America's primary care physician, so I imagine you're seeing a lot of this too. Is this chronic progressive shoulder discomfort? But like if I saw like a 30-year-old athlete with like a shoulder problem and I wasn't sure what was going on, I'm sending them to ortho anyway because I feel like there's more of a functional lifespan that I'm worried about there.
I'm glad you asked that because the fear is like I feel like the teaching is well if it's a full tear then you need surgery. If it's not so it's you don't want to you're terrified that you're going to make things worse by saying physical therapy. But if it's going to help in any case, that just feels better no matter what.
Yeah, I think you have to be very careful about what you ask the therapist to do. And if we're in a hurry, we can say eval and treat. And if you're not careful about it and your physical therapist isn't really trying to figure it out, one of the most favorite physical therapy things for shoulders is this like walk up the wall with your fingers.
Oh, yeah.
So if you're basically saying, okay, I want you to, on that sore spot on your chair, I want you to bite that 100 times a day. That's not going to help it go down. So a lot of repeated overhead positioning of your arm, not the best for this diagnosis. So if we can at least let them know that we think they have subacromial space impingement, we're going to avoid overhead positioning until the symptoms improve, and we're going to emphasize these exercises.
Yeah.
There's another one called scapular retraction, which is basically, I'm a big sloucher. If you don't slouch and you bring your scapula, your shoulder blades together behind your back for posture, that has been shown to open up the subacromial space also. So sometimes that postural correction, those are the kinds of things in physical therapy that will help, and certainly aren't going to be a big harm if it's a rotator cuff tear that eventually needs surgery. Doing those things isn't going to set you back.
So like anything that we talk about in ortho, so NSAIDs if it's safe for the patient, physical therapy. We talked about subacromial space injection for people with impingement. And then the surgical referral, we talked a little bit about that too. Like the person with a traumatic injury and it's very acute seeming, that person might go to surgery sooner.
Right.
But for these chronic tears, it seemed like from your book that it's tricky to fix those. And there's some new, I don't know how new it is, reverse shoulder replacement surgery is something that's on the table.
So one thing on the continuum that we didn't visit is sort of the big daddy of all of it, the very, very end on the extreme end of the continuum, which is a rotator cuff tear that's so big, it's not fixable. And that irreparable rotator cuff tear was something we really were challenged with treating for a lot of my training. But starting maybe 15, 20 years ago, I had nothing to do with it, but they came out with a shoulder replacement that can be used in a rotator cuff deficient shoulder. And that's what the reverse is. And we can go into why it works. It's a little complicated. It may be hard to convey to people listening.
Yeah, it's very well explained in the book, but
Yeah, great. Okay, good. Once you see it and understand, it's like, wow, that's cool. Why didn't I think of that?
Yeah.
But that's a solution to a patient with a chronic massive rotator cuff tear that's not fixable.
Okay.
Yeah, that's the one that's tough to fix, is the really huge tears. The smaller tears actually are easy to fix. And if you do fix them, you have to do that operation in conjunction with a subacromial decompression. And that's just a way of saying we're going to take a little Dremel tool, we're going to sand off the underside of the acromion, any bone spurs, plus maybe 30% of the native bone, to open a space so wide that nothing's going to touch there ever again.
That seems smart.
Yeah. Otherwise, your repair is just going to have the same fate as the native tissue did. So those go hand in hand.
Okay. Paul, any other questions about impingement? I think we've done a good job and really helpful the way you think of the continuum and trying to sort out where they are in the continuum. That's definitely going to be very helpful for me moving forward.
This comes up all the time, so I just want to hear it from the source itself. When would you consider MRI for these patients? Then I guess, is there any role for plain film imaging? Because I think this is something like you're just tempted to do something diagnostically, and if you think this is impingement, would a plain film X-ray ever be helpful? So could you just talk to us about the role of imaging in these particular cases before we move on?
Yeah, that's a really good question. I think that we get a lot of MRIs for these shoulders that we probably don't need, but and they are helpful. It's always comforting for me as a surgeon to go to the operating room with as much sort of anatomic information about what I'm going to find in there as possible. And technically speaking, I could manage an impingement patient all the way to and through surgery without an MRI. So picture this scenario. We have this patient you described. We've diagnosed them with impingement. We think on the continuum it's maybe tendonitis or perhaps a tear. We did a cortisone injection and they got a lot better, completely asymptomatic for maybe 2 months, but then it came back. And 2 months a little early to do another shot. We waited another couple months, gave another shot. Same result. Great result for a month or two, but then the symptoms came back. That result, the improvement that that patient got, even though it was temporary, helps me cement the idea that this is impingement, okay? Because the medicine was delivered in the subacromial space. That made a big difference. I could go with that patient, since we can't keep doing these cortisone injections, they're needing them sooner than I can repeat them. I could go into that patient with a plan of removing the underside of the acromion, which will solve their impingement if it's bursitis. It will solve their impingement if it's rotator cuff tendonitis. It'll solve the impingement part if it's a cuff tear. When I'm in there, I can just peer down at the rotator cuff with my scope and tell with much more accuracy than an MRI if there's a tear or not. And if there's a tear, as long as the patient and I both understood on the front end, if I find a tear, I'm going to do the extra step of fixing it. And that's on the consent and all that stuff. And if I don't find a tear, we'll cure you by doing the subacromial decompression. So technically, I could get all the way through the whole thing, including surgery, without an MRI, if I'm really confident that they're impinging and I'm going to go in to do the subacromial decompression. In our market, it's funny, insurance companies won't let me book the surgery unless I've gotten the MRI, which, I've given up on trying to figure out the logic in a lot of the things in medicine. That's one where I had to wave the white flag and just say, okay,
Yeah.
I'll order it.
Yep. You won't win that fight.
Yeah.
Let's get to a case from Cashlack. And this first case, audience, I'm going to spoil it. It's a case of glenohumeral joint arthritis. And Ted, I'm going to ask Paul to read it because everyone loves to hear Paul speak.
Sure. We're going to talk about Jacqueline. She is a right-handed 55-year-old female. She's a former college athlete with type 2 diabetes, high blood pressure, and obesity who's presenting with right shoulder pain and stiffness that have progressed over the past 1 to 2 years. She actually had to stop pitching for her beer league softball team because it's been bothering her so much. Her friend told her it's probably frozen shoulder. On exam, she has full active range of motion in the left shoulder, so the one that is not affected, and no pain. But on the right-hand side, she cannot fully flex, extend, or abduct her right shoulder. And with passive external rotation with her elbows at her side and flexed at 90 degrees, this causes pain, and she's too stiff for full rotation. So Matt already ruined the diagnosis of the case, the best part. So we're already calling this glenohumeral joint arthritis, which this is consistent with. But can you talk us through, like, what background should we suspect when someone comes in with shoulder pain? So if we look at a patient we're pre-gaming, we see on our schedule shoulder pain, what things would make us think about glenohumeral arthritis kind of right out of the gate?
Yeah, so you've got a couple clues in this patient's history that are sort of classics. What happens in glenohumeral joint arthritis, and I'm talking about osteoarthritis of the glenohumeral joint, wouldn't be necessarily true of rheumatoid arthritis or other pathology, but the most common thing you'll see is osteoarthritis. And that's a condition where the cartilage coating on the surface of the ball and the cartilage coating on the surface of the socket are worn down. And in the extreme case, there's exposed bone, which is sensitive, has a lot of nerve innervation, whereas the cartilage coating before it's completely numb. So all of a sudden the joint gets stiff because that bony surface is rough instead of slick and slippery like the cartilage coating was. And it's painful because the cartilage coating is one of the few things in our human bodies that has no innervation, no feeling to it, and doesn't hurt at all. In fact, we can't even understand or feel that it's been moving against the socket when we move our shoulder around. So when they wear off, you get a sore shoulder, and it takes time for that to happen. So, and like an 18-year-old, I wouldn't put osteoarthritis on the differential at all, because in 18 years, even of rough 18 years, it's going to be a challenge to wear through that articular cartilage down to bone. You put a couple of nice little Easter egg clues in there for me. One is she's over 50. So that's enough decades to wear down, especially if you have a high mileage shoulder, and she being an athlete in her younger years, those kinds of activities often will advance or speed up the wear rate. All of us every year, just like the tires on your car, all of us wear a tiny, tiny film of that cartilage away every time we move. More severely in the weight-bearing joints like knees and hips, but certainly in shoulders as well. So if you guys in internal medicine ever are successful at keeping us all alive 200 years, one of the challenges will be in 200 years, pretty much all of us in the weight-bearing joints are going to wear all the cartilage down to bone. So we have to figure out a way to deal with that. It happens less quickly in shoulders. And when it happens in shoulders, if you are unlucky enough to wear it out and get down to bone on bone, it's better tolerated in non-weight-bearing joints like shoulders than in knees and hips. It's really crippling. You can't get from here to the door without using your knees and hips, but your shoulder you can oftentimes get by with minimizing its use and range of motion. So your original question was, what things in the history are we looking for? And I think if you were to summarize it, it would be a high mileage joint, and that can either be normal use over a long period of time, like 60s, 70s, 80s, or a younger person, but with a job or a sport that put a lot of force across that glenohumeral joint. And just like a bearing in a machine, that added force is going to speed up the wear rate.
And in terms of comorbidities and risk factors, looking at this patient, it seems like I would almost be, just based on demographics and comorbidities alone, I would think adhesive capsulitis. So this is a woman with type 2 diabetes who's having shoulder pain. Is there a lot of overlap in terms of risk factors there? Is that reasonable to say?
I think that there isn't as much overlap in risk factors, but there's a huge overlap in clinical presentation. So both of those, in fact, they're almost indiscernible on physical examination, because in both instances you have limited range of motion, and if you try to get to the limit of range of motion, there's significant pain. And so they're almost indistinguishable on physical exam. So there's a ton of overlap there.
Yeah, I mean, I do struggle with this sometimes. Is it safe to say that anyone under 40 years old, like this diagnosis is probably not on the table, like for glenohumeral joint arthritis?
Yes, I think it's, definitely with every decade younger, you can be more and more confident it's not going to be.
It's not going to be that. Okay. Tell us how you differentiate it from frozen shoulder, because you mentioned that they're hard to differentiate just on the exam alone. And we'll have an exam video that accompanies this episode. But what sort of things should we do that can help us sort this out?
Well, unfortunately, there probably isn't anything on the exam.
Right.
So the thing that's going to tell the difference is X-ray. And it's easy for me because I have that right next to my exam room, and I can shuttle somebody off and get an X-ray in about 10 seconds and have the images to look at instead of just a report. And so I'm spoiled that way. You guys and a lot of your listeners don't have that. But that is probably the most useful tool to sort somebody with a stiff, painful shoulder into either the glenohumeral joint arthritis bucket or the adhesive capsulitis bucket. So if you take that X-ray and there's still a very wide joint space, so a clear space on the image between the humeral head and the glenoid, the only reason there is a clear space is that cartilage coating we just talked about, it's not visible on the X-ray. And the thicker it is, the more space there'll be on the X-ray between the ball and the socket. So if there's a good 1/4 inch of thickness of that space on the image, then you've got a healthy layer of cartilage on the ball and the socket, and it's not glenohumeral joint arthritis. In that case, it's going to be adhesive capsulitis.
And how do you explain adhesive capsulitis to a patient?
Yeah, it's a really good question. The layers of muscle in our shoulder are stacked on each other like the sheets on your bed. And to work right, they have to glide around like the sheets on your bed. And unlike the sheets on your bed, if they lay against each other without motion, they will actually stick together. And that abnormal connection is what we call adhesions. If you are in a coma in the ICU from a car accident or something, if the therapists don't come around and passively range your shoulders, the shoulders will freeze up and get adhesive capsulitis. If it's even more apt to happen if you have an injury or an operation where blood gets between those layers and the blood then hardens into adhesions or scar tissue that tacks all of that together. For some reason that I can't explain, diabetics have a higher incidence of adhesive capsulitis. And the way I remembered it for the boards was that, sugar's sticky, and so maybe that's sticky. That isn't it.
Right.
It's not.
Yeah, because most of the patients that I see do not have the risk factors, like, that they were immobilized in the ICU or that they had a traumatic injury to their shoulder that caused bleeding. So,
yeah.
It does seem to be a pretty common thing that we see.
And I see it a lot as a sort of secondary diagnosis. So let's say you have something else like shoulder impingement. And the impingement makes you consciously or subconsciously limit how much you use your shoulder. That lack of motion can allow adhesions to occur and cause, as a secondary thing, adhesive capsulitis. And that makes it diagnostically way more difficult for me, because I can't even do some of the maneuvers I need to do to check for impingement because they physically can't get there in their range of motion. So I always worry in anyone I see with adhesive capsulitis, I have to be diligent to see, is there some trigger for it that is causing them to keep their shoulder more still, which is then causing the adhesive capsulitis. Because if there is a trigger like that and you don't identify it or treat it, you can treat the adhesive capsulitis with therapy or even a manipulation under anesthesia, but it'll come right back if they can't move their shoulder afterwards because they have a big subacromial spur or something like that. So always remember, it could be a secondary problem as a result of something else that's the primary problem.
You may not know the answer to this, but going back to the imaging, it's funny, there's such wild enthusiasm for point of care ultrasound in medicine, except for MSK. Like if you ask any POCUS expert, like cardiac, pulmonary, they love it. And you're like, what about the shoulder? They're like, ooh. But I feel like this might be a role for that. Are people looking at POCUS to kind of make this diagnosis as well?
I think it's most useful right now, and this is evolving. I mean, it's amazing. This is fast-paced evolution in terms of how many times you'll see an ultrasound in one of our offices or one of your offices, and what it's being used for in terms of imaging and also guiding things like injections. And I think in a couple of years, it'll be like mainstay practice in everybody's practice. Right now, the majority of orthopedic offices don't have it. The majority of our providers in our market who are primary care don't have it, but every year more and more people are getting it. As it's evolving or increasing in popularity, we're also learning all the fun things it can do. Right now, it's used most extensively to evaluate the rotator cuff. And it can be used to diagnose a hole in a rotator cuff, a tear in a rotator cuff, and it does a good job on that. I think it's harder for it to measure the thickness of articular cartilage, and it doesn't do well on bone. So unless there's something about it I don't know, it wouldn't be my go-to for this problem, glenohumeral joint arthritis.
Let's talk about the physical exam maneuver that you use to diagnose. Like, which one's most helpful? We talked about limited range of motion, pain, and stiffness. What's a quick and easy way to test this in primary care to see if you think they might have either glenohumeral arthritis or frozen shoulder, knowing that we're going to get an X-ray to differentiate the two?
Yeah, there is one physical exam maneuver that is helpful. So let's say we're seeing a patient and they're complaining of right shoulder pain. Well, on our physical exam, we start moving their shoulder around, and pretty much every direction we move it, they get to a point and they stop us because it hurts too much. If the motions we're doing are forward flexion, bringing the arm straight up, like you would to signal a touchdown, or bringing it out to the side like you would to do a snow angel, those motions, forward flexion and abduction, once you get above 90 degrees, you can be stopped by impingement pain. Okay. And so that maneuver will cause pain at about 90 degrees in the impinger patient, but it will also cause pain and they'll make you stop for the glenohumeral joint arthritis because you're just reaching the end of their range of motion,
Right.
and the patient with adhesive capsulitis. But what's different among those patients is if their elbows are at their side. And when your elbows are at your side, the subacromial space is wide open and you shouldn't have any impingement pain. And then if you start rotating with your elbows at your side, rotating your forearms out in external rotation, that range of motion in somebody with adhesive capsulitis or glenohumeral joint arthritis will be very limited compared to their opposite side. So it won't rotate out nearly as far as their unaffected side. And that wouldn't be true of anybody with impingement, because with their arm at their side, the space is open, nothing's hurting. Right. They should be able to freely do this all day long. So that's a really strong clue if they have limited painful range of motion with their elbow at their side, especially external rotation. I haven't seen a patient yet who doesn't have internal rotation to the point where they can put their hand on their tummy. You could do internal rotation behind your back and they'll be limited there, but there's complications in that test. I think the best test to do is you have the patient's hands, elbows at their sides, hands straight ahead, sort of like I'm holding up a bank kind of thing.
Yeah.
And then rotate externally, keeping your elbow at your side, and compare. Just watch them do it in front of you.
Just the active range of motion is fine.
Yep, or you can do passive. Either way, you'll be stiff and limited range of motion, either way with active or passive, but you're looking for a side-to-side difference, right to left, with the affected side having less range of motion and more discomfort than the unaffected side.
And this is, I just want to make sure I'm understanding, this is different from external lag, where you're evaluating rotator cuff, where they're just not able to maintain in full external rotation. Is that right? So
Yeah.
they're not even getting there to begin with. Is that
Correct.
right?
Yep.
Okay.
It's
Gotcha.
limited range of motion, active and passive.
Okay.
So our patient Jacqueline, the 55-year-old, we get an X-ray and the joint space is not preserved. So we are saying this is glenohumeral joint arthritis. And how would you talk to her about what she can expect? What treatments can we offer her?
Yeah, I think it's really important that she understand that the root of the problem here is that cartilage surface has worn away and that we humans have not figured out a way to grow it back. And once she understands that, she's going to sort of understand where she is. This is a degenerative process that will never reverse, that with time will continue to get worse. The patients always ask me, like, what can I do to stop the wear rate? And you just have to like put yourself in a straitjacket and never move. And it's true that probably would stop your wear rate, but obviously it's not practical or possible. So everything she does, every time she reaches to put a coffee cup on the shelf or even bring a spoon to her mouth, she's rubbing the ball against the socket. And all humans have some finite wear with that. So it's going to slowly, not in days or weeks, but years or decades, it's going to get worse. And so that's out there in her future. She's only 55, so she has decades ahead of her. And what we've got to try to do is mitigate symptoms with non-surgical care. And when those aren't adequate, then there's an operation that can bail her out. So it's not all dismal. It's not like she has no options, but thinking that I'm going to do physical therapy 2 weeks and it's going to be back to normal, it's not realistic.
So this is NSAIDs if they can tolerate them, physical therapy, and then are you doing injections, steroid injections for this as well?
Yeah, there's a corticosteroid injection that works really well in the glenohumeral joint. So that's on the menu as well.
And then you've told us before that, like for hip, they usually don't try to replace them before age 60 because there's a 20-year life on it or something like that. Is it with shoulder? Is there such a time period that we know shoulders last?
Yeah, it's less precise for us about how many years you'll get out of it, but definitely the philosophy is the same, which is it has a finite lifetime. So we want to try to defer it as long as we can. And you don't get a worse result necessarily if you wait an extra year or two or 3 or 4 or 5 if your symptoms are tolerable or treatable with non-surgical means. So definitely the surgery is the nuclear weapon that we pull out. If nothing else is working and the patient can't sleep at night and they're just abjectly miserable, then it's a good solution for them.
Okay, Paul. So at this point, we've covered impingement, we've covered glenohumeral joint arthritis, and what's left to talk about is the AC joint. And Paul, can you start us off with the case?
Cannot believe you're just giving these away. Sure. So we're going to talk about James. He's back. His left shoulder feels better after physical therapy, so that's great. However, he's now developed right-sided aching shoulder pain. For this case, it's wintertime, and it hurts when he puts on his scarf. Very specific detail. There is no recent trauma, but he remembers separating his shoulder during high school football, though he doesn't quite remember what that means specifically. On exam, he has normal strength and range of motion in the right shoulder. You do notice some tenderness palpation over the AC joint and a bump deformity. The crossed arm impingement test reproduces pain in the right shoulder. Matt gave us the diagnosis, but maybe just sort of talk us through your approach and when you might suspect AC joint arthritis or AC joint pathology.
Yeah, so this has all kinds of great, this is really a softball because it's got everything. I mean, I don't think I even included all of those pertinent positives in my book because you thought of a couple that I've forgotten about. So yeah, that patient has shoulder pain. So they're in the general population of shoulder pain patients. Our job is, do they go in the impingement bucket? Do they go in the glenohumeral joint arthritis bucket? Do they go in the AC joint pathology bucket? And where he's tender is a strong arrow towards AC joint arthritis. The collarbone is probably the most palpable bone, or one of the most palpable bones in a human. Even a heavy person, you can find the clavicle on all of them. And if you just walk laterally on it, you'll get to the AC joint. And oftentimes you can feel a little step off when you're there. Sometimes you can't. But if you get out to that very end of the collarbone and it hurts, that's a strong signal that the pain's coming from the AC joint. You can't do that with like the glenohumeral joint. You can't like palpate on it and press on it and poke that bear in the eye. You can't, but the AC joint you can. So that right there is a really strong indicator for me. The cross-arm impingement sign, when it's positive, it's meaningful. I found people with bad arthritis in the AC joint for whom it's not positive, but it's positive in him, which is great. So he's reaching across his body, sort of to like imagine patting yourself on the shoulder, which I do a lot actually, on your opposite shoulder. When you reach around to do that, you're sort of compressing the acromion against the clavicle. You're squishing that sort of irritated joint together. And if that reproduces your symptoms, that's classic for the AC joint. And then in the history, he's got a neat little Easter egg. And then he said that he had an AC joint separation. So he's had trauma to the AC joint. And that trauma may have injured the surfaces of the clavicle or acromion or both. And whenever you've got an injured surface and then years of use, you can get accelerated wear. So that's a clue that he may have worn out his AC joint and has AC joint arthritis. So that thing's loaded with great indicators that we should steer toward the AC joint bucket and not one of the other two things we've been talking about.
Yeah, we talked with a Dr. Carlin Center in the past about shoulder, and she was saying she like always palpates the AC joint because like it's just like one of those things. Like if you forget to do it, and then you could miss something there. That could be part of what else is going on. So it's one of those things that I've always always try to press on that and check if they're tender there. Sometimes you find something, sometimes you don't.
And it's nice to do them both at the same time, with a thumb on each and just compare right to left simultaneously as you're marching out
Oh, that's a good.
from the
Okay.
sternoclavicular joint. Because some AC joints and I have some patients, if you look at them, they have pain. So touching them anywhere is going to be painful.
Right.
So I really like having a control.
That's a good point. How are we going to treat this gentleman with his shoulder pain that's classic for AC joint arthritis?
I have not learned yet any physical therapy maneuvers that are helpful for mitigating that discomfort.
Mhm.
So if they exist, have your listeners let us know about it, because
Sure.
I'd love to know that. I think oral anti-inflammatory medications can help, and a cortisone shot into that little AC joint is really helpful. Again, shoulder joints, they're non-weight-bearing joints. A lot of times we get a lot more mileage out of a conservative thing like a cortisone shot and can avoid surgery easier than in a weight-bearing joint. So a little dose, maybe a half dose of corticosteroid, and this could be Depomedrol or Kenalog or Aristocort, and I'll mix it with a half cc of lidocaine. So now we're up to a cc, which is a lot to jam into that little joint. Anything more than that, I think, is really a challenge. And then you've got to get the needle into that space, and it's a tiny little crack. And the only way I'm successful at doing it is to take my best guess at where the AC joint is, and then place my needle perpendicular to the surface, and then push down. And pretty much every time I hit a bone, so I'm not in the right spot, but I'll march either medial or laterally, and you'll.
This sounds like LP.
I was just going to say this is the LP from the internist.
Maybe it's the same technique.
Keep bouncing
you guys
off the
for that.
spine until
So
you.
yeah, just keep pecking at it, and one day you will drop into a little valley there, and that's the AC joint.
Yeah.
And once I'm in there, I don't want to go too far because you actually will be in the subacromial space if you
Yeah.
go down through the backside of it. So a couple millimeters into that little gap, and then plow that medicine into that tight space, which is sometimes uncomfortable for people. But lidocaine will help you out after a second or two. And the result of that injection is very helpful for me, not only as a therapeutic measure, because it's likely to do well, but and last a long time, but it also, if they got better, I know I've done the right thing by putting them in that bucket.
This feels like a place where POCUS might come in handy if you're able to actually see that AC joint
if
for
you
that.
can see the AC joint, that would be really helpful. And I think in general, ultrasound's been really helpful for us in shoulders, both for diagnostic imaging and also guiding needles into spaces, subacromial space or glenohumeral joint.
All right. And we'll have a quick video of some of the shoulder maneuvers to accompany this. And Paul, any last minute questions?
I want to hear about the surgery for the AC joint because I think I know what the answer is, but I'm fascinated by this. So let's just say
yeah.
it's refractory to our injections. They don't help out that much. If you need to surgerize a patient with AC joint arthritis, or not need to, but that's what the patient really wants. What does that look like? What kind of things are you doing procedurally?
Yeah, it's an interesting thing because in general, we have three options surgically for an arthritic joint. In knees and hips, we put in artificial surfaces that are numb and slippery like the cartilage used to be. So that's a joint replacement. In some joints like the ankle, we actually fuse the bones together. So the problem is bone rubbing against bone. Doesn't happen if they're
Just get rid of that
bolted
joint.
together.
Yeah, love it.
So the downside is stiffness, but it's tolerated in some joints better. I can't think off the top of my head of another one that we fused that has trivial disability from being stiff. But ankles actually tolerated pretty well. So that's a surgical option, is fuse the joint. And then the last one is what we call a resection arthroplasty. which means we're going to chop out the joint. We're going to hack off the end of the collarbone, take about 1 centimeter off of it. And if I take 1 centimeter off the collarbone, there's no way that collarbone's ever going to see or touch the acromion again. So there's not going to be any more bone-to-bone rubbing if I do that. And we can get away with it especially well in the AC joint because there are these funny little remote ligaments that go from the coracoid process to the clavicle. And since the coracoid and the acromion are two parts of the same bone, if we stabilize the clavicle to the coracoid, we're actually stabilizing it just as much to the AC joint. So normally if you hack out that much bone and take the capsule and all that stuff out, you could create instability here. But having those remote ligaments stabilize it, there's no instability when you do that distal clavicle resection. It's also got a nickname called the Mumford procedure. And that's the surgery we would do at the AC joint is a resection arthroplasty to treat the arthritis, not a little replacement. And fusing it would not be good because it's weird to think about, but this is the only connection of our arm and it's the only bony connection of the whole thing, arm, shoulder, elbow, hand, everything is hanging on this.
Yeah.
There's no connection here. This moves around all over the place. So fusing this really can limit what you can do. I mean, you still have the glenohumeral joint motion, but there's a lot of stress on this. So you want that to have a little bit of motion the way it's designed to have.
Yeah. I think I read that you called it like a blood plug or something, fills that space. And that was quite the visual.
Yeah, so it immediately fills in with blood, and then that matures into like a rubbery scar kind of cushion that keeps the two from touching each other.
So I think what you're talking about fixing, was it trigger finger? I'm trying to remember where you sort of just make the incision and it kind of opens up and then forms a scar and that just creates a little bit more space. It sounds conceptually fairly similar to that. Interesting.
Okay, Ted. So as always, we love hanging out with you, but our time has to come to an end. So can you give us just a couple take-home points that you want the audience to remember?
Yes. One has to do with differentiating impingement pain patients from patients with glenohumeral joint arthritis. And they can be very similar in presentation as far as having pain with forward flexion and abduction, and some of the palpation stuff can be painful on both. But the real differentiator is how they behave with their elbow at their side for passive or active external rotation. So realize that the impingers will be able to do that all day without problem because in their elbow at the side position, the subacromial space is wide open. Nothing's being impinged against. But the glenohumeral joint arthritis person will have pain and stiffness asymmetric to their other side. So it's easy to see. You have them roll both arms into external rotation with the elbows at the side. You'll see the difference. And that isn't explainable by impingement. So now you know that that patient's not in this big common thing, which is impingement that almost everybody is. It's something different. It's either adhesive capsulitis or glenohumeral joint arthritis, and the x-ray will sort those two things out.
Well, I feel very comfortable about shoulder. I will tell people they should check out the book.
Check out the book.
The book, it explains everything very well for all the joints that we've talked about with you in the past.
I don't think we've said the name of the book out loud yet. It is Practical Office Orthopedics, by the way, in case you're actually looking.
Which we are not sponsored by.
Netflix.
We're just,
we keep trying.
Just are very fond of Ted.
I'm going to send you guys a 6-pack of beer. I don't know if that qualifies as sponsorship.
That's fine.
Or,
we're easily bought.
Okay.
And with all of that, this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we need your feedback, so email us at askcurbsiders@gmail.com. It also helps a lot when you subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts. A reminder that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. I wanted to give a special thanks to our whole Curbsiders team and to Chris the Chew Man Chew for helping with the video for this episode. Our technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, remain Dr. Paul Nelson Williams. Thank you and goodbye.